My name is Rita Brown, and I am the President of the Australian BPD Foundation. I'd like to welcome everyone today to our online forum, BPD in Adolescence, Myths, Identity and Treatment with Dr. Carla Sharp. As we start, I'd like to acknowledge the traditional owners of the lands upon which we're meeting today, both from within Australia and overseas, and pay my respect to their elders past, present and emerging. A very quick introduction to the Australian BPD Foundation, which was launched in 2013. We are a group of volunteer consumers, carers and clinicians who are passionate in engaging a positive culture around borderline personality disorder and promoting the ready availability and accessibility of appropriate services for everyone impacted by BPD. We are registered as a charity by the ACNC and all donations are tax deductible. In Australia, BPD Awareness Week is the first week in October each year, and we have a number of events planned. Since May is BPD Awareness Month in the US and UK, and with the aim to increase awareness in Australia, we're hosting this event today with Dr. Carla Sharp. It's great to see people attending today from around Australia, in addition to Chile, China, and Mexico. Carla was unable to join us live today, so I'll shortly play her pre-recorded presentation, and she will join us later to respond to questions. You're welcome to ask any questions via the chat box, and Associate Professor Sathya Rao, the Clinical Director of Spectrum Personality Disorder Service in Victoria, will collate the questions and facilitate the discussion with Carla in about an hour. I'd now like to introduce Professor Carla Sharp. She holds a number of senior positions at the University of Houston and has significantly advanced the scientific understanding of the phenomenology, causes, correlates and treatments of personality pathology in youth. She is the current president of the International Society for the Study of Personality Disorders and incoming associate editor for the APA Journal of Personality Disorders, Theory, Research and Treatment. In addition, she has been published extensively in numerous journals and books. I've heard Carla speak on a number of occasions and find her an inspiring presenter. Before I play her video, Carla speaks about a number of case studies, and some people may find some of the scenarios a little bit distressing. We just encourage you to do whatever you need to do to support yourself if this is the case. I'll now play Carla's video.
Hi there. I am very pleased to be joining you today from Houston, Texas. I'd like to thank the Australian BPD Foundation for inviting me to be part of your program. I will share my screen and then we will get started. The topic of my talk today is borderline personality disorder in adolescence, myths, identity, and treatment. I want to start with a case, Henry, who is a 15-year-old male, white male who identifies as trans. He lives with his adopted mother, stepfather, and 5-year-old brother who is biological, unrelated to him. He was referred for an evaluation after a recent suicide attempt. Henry reports having thoughts of death or dying at least 3 times a week. His parents report that he made an impulsive suicide attempt by taking pills from his parents' medicine cabinet the previous week, which led to an acute inpatient hospital stay. This happened after a breakup with his girlfriend who felt that she could not commit to him. During admission to the hospital, the parents reported Henry has intense anger outbursts. Henry says these are the only times when he feels emotions, and that most of the time is emotionally dead or has no feelings inside. Henry also reported that he has no friends and feels utterly alone. His mother described him as a follower who succumbs to peer pressure, yet does not fit in. Henry reported not feeling like he belongs to any peer group at school and feeling like a black sheep of his family because he ruins everything. During his inpatient stay, Henry was diagnosed with depression, general anxiety, insomnia, ODD, and ADHD, and his parents are now considering homeschooling. As a baby, Henry's mother described him as often fussy and not easily soothed. As a toddler, she reported that he was very sensitive and had frequent tantrums. His preschool teacher described him as active and energetic. Throughout elementary school, Henry began exhibiting symptoms of hyperactivity and anxiety and was diagnosed with ADHD at age 6. His teachers reported that he had difficulty staying in his seat, asked excessively to go to the bathroom, and would talk to other students during quiet time. During parent-teacher conferences, Henry's teachers reported that he had difficulty making friends and was often seen playing alone at recess. When he did make friends, he was very anxious to impress them, and his feelings would get hurt easily if friends chose to play with someone else. In third grade, age 9, he began exhibiting signs of school avoidance and reported somatic symptoms of anxiety, including stomach aches, headaches, and nausea. At this point, in addition to his ADHD diagnosis, he received a diagnosis of school refusal and generalized anxiety. When he entered middle school at age 12, he became increasingly defiant and began receiving detentions for tardiness and classroom misbehavior. He also reported increased stress related to schoolwork, developed a temper, and talked back to his parents on a daily basis. His psychiatrist diagnosed him with oppositional defiant disorder. His mother noted that he was often in a bad mood or irritable with the family nearly every day, but thought that he was just going through a teen phase. Henry reported that at that time he felt sad much of the time, and the only time that made him happy was when he was playing video games. At age 13, aging into adolescence, Henry's feelings of sadness increased shortly after his only friend moved away. Henry reported cutting himself on his arm with a knife 9 or 10 times during 8th grade. He reported doing this for a variety of reasons, most notably being bullied by peers when he insisted that he be called by the pronoun them, they, or when his feelings were dead, and he wanted to turn them back on. At this point, he was put on a mood stabilizer to try and manage the combined internalizing and externalizing symptoms. So Henry's case will ring true for most clinicians working in the field of personality challenges, but also many parents who have gone through this journey with a child who receives multiple diagnoses from early on, and when at no point in meeting with mental health clinicians, personality was considered or assessed or treated. And so the reason for this lack of focus on personality function more generally, but also personality disorder in particular, is because of a range of biases or myths that up until about 5 to 10 years ago have really dominated the field. The first is that the psychiatric nomenclature, the DSM-5 and the ICD-11, does not allow the diagnosis of PD in adolescents. The second one is that certain features of Bpd are normative and not particularly symptomatic of personality disturbance. So kids will grow out of these sort of impulsivity and emotion dysregulation, and it's quite normal for all teens to go through the storm and stress period. The third is that symptoms of Bpd are better explained by traditional axis 1 disorders. And so we don't really need a construct of personality to capture what is going on with a young person, but instead we can use, like in Henry's case, anxiety, depression, substance use, ADHD, and so forth to describe what might be going on with a young person. The fourth has been that adolescents' personality is still developing and therefore too unstable to warrant a PD diagnosis. And so really we need to wait until age 18, until personality is fully formed, and then we can potentially consider a PD diagnosis. The fifth one is that because personality disorder is long-lasting, treatment-resistant, stable, and unpopular to treat, it would be stigmatizing to label an adolescent with BPD. And in fact, this is the the reason for why most clinicians would say that they don't want to diagnose personality disorder in young people. So what I'll be doing in this sort of first 20 minutes of the talk is just really debunking these biases or myths very, very briefly. Sometimes I have given longer talks on the evidence in support of the opposite of these myths. But today I just want to give you a very quick taste of that. So in terms of that first bias or myth that's been hanging around and in some cases still hang around, it is actually the fact that DSM-5, since DSM-3, the third version, has allowed for the diagnosis of personality pathology in young people. This has been continued in DSM-5, as well as the ICD-11, which will take effect in 2022. The diagnosis of BPD and other personality disorders in young people have also been legitimized in several national treatment guidelines, like the National Institute of Health for Health and Care Excellence in the UK, and the Australian National Health and Medical Research Council. And so this idea that we're not allowed to somehow diagnose BPD in adolescents is not true. We are allowed to do that, and as this talk will progress, you are encouraged to do so. The fact that we're allowed to do so has led to the development of a whole range of personality disorder measures and tools that have been validated for use in young people. This is out of a table that Peter Fonagy and I published in Journal of Child Psychology and Psychiatry in 2015. And it really shows all of the evidence in support of the internal consistency, interrate reliability, factor structure, and construct validity for a whole range of measures, interview-based measures, parent report measures, self-report measures, and so forth. It continues here. There are tools to validly and reliably diagnose these disorders that are legitimized in the psychiatric nosology. What about this idea that certain features of BPD are normative and not particularly symptomatic of personality disturbance? Well, what we do know from multiple longitudinal studies now is that when we do track borderline symptoms over time, we do see a normative increase. So it's partly true that all teens become a little bit borderline as they age into adolescence. But the important point here is that between ages 9 to 28, BPD traits decrease by 60% and they level out from ages 28 to 38. So most kids and young people follow a normative decline in these traits over time. What we do see, however, is that a subset of these young people who reach this peak don't follow the normative decline. These are the young people in the red line there, and they are the ones at risk for having a personality disorder. Now, all of them won't have PD because we know the prevalence rate for personality disorder is not 21%, but these are the ones we want to keep our eye on that seem to have this sort of pattern of high borderline traits, and they are the ones that potentially need intervention and treatment. So it's not really true that all teens grow out of it. Yes, there is this normative increase, but there's also a normative decrease in some kids that get stuck. What about this idea of symptoms of BPD being better explained by traditional axis 1 disorders? This is the idea that we don't really need a construct of personality function to describe what might be going on with someone or to treat what might be going on with someone, that the disorders of internalizing and externalizing, so depression, anxiety, substance use, ADHD, and conduct problems are sufficient to capture and treat what's going on with young people that show some of these challenges. So this is a study, a very nice study published in Journal of American Academy of Child and Adolescent Psychiatry last year that followed up more than 2,000 British children who were assessed at age 12 with BPD. And then again later, I think at age 18, they were followed up. And here you can see in the dark blue bar, the children who had high borderline symptoms at age 12 compared to the children who had low borderline symptoms at age 12 in the light blue. And across a range of health outcomes, here's poor mental health, here's poor functional outcomes, just in terms of sexual risky behaviors and so forth, adolescent victimization, on all of these outcomes, the kids with high borderline traits at 12 evidence much poorer outcomes than other kids. Critically, here the authors presented a table where in column 2, they show that these poor outcomes hold for most outcomes when controlling for internalizing and externalizing psychopathology. So there's something special that the borderline diagnosis or borderline increase in symptoms brings to the table over and above internalizing and externalizing symptomology at time 1. This is a study, collaboration with Kathy Winsper, actually published in the Australian, New Zealand Journal of Psychiatry, where we controlled for depression in looking at whether borderline symptoms predict hypomanic and psychotic symptoms 10 years later. And again, we showed a unique relationship between borderline symptoms and outcomes, even when controlling for internalizing symptoms. There's another way of looking at this, and that is to take a group of young people who meet criteria for BPD and compare them to a group of young people who don't meet criteria for BPD, but do meet criteria for severe internalizing and externalizing psychopathology. And they're severe because they're all inpatients, these black and dark gray kids. But this group meets criteria for BPD while this group does not. And then compare them with healthy controls. And as you can see, for a range of outcomes, this is mentalizing, implicit mentalizing, and hypermentalizing. You see reduced implicit mentalizing capacity in the borderline kids being significantly different from psychiatric controls and healthy controls. Similarly, you see increased hypermentalizing in the borderline kids compared to the other two groups. Similar pattern for experiential avoidance. This is not being able to stay in touch with your own thoughts and feelings. Again, there is a significant difference between the psychiatric controls in the borderline kids and the healthy controls. Similar for emotion dysregulation, same pattern. So BPD brings something extra to the table in terms of distinguishing these kids from kids with very severe internalizing and externalizing psychopathology. Another way to look at it is, of course, longitudinally. And this is a very nice paper that Stephanie Stepp did, in which she reviewed all the prospective studies on the development of BPD and looked at early risk factors, including early psychopathology. And what she found was that internalizing and externalizing problems precede the onset of borderline personality disorder and traits, borderline features in adolescence, but not the other way around. So it's not usual for us to really see an 8-year-old who would be considered borderline and then develop internalizing and externalizing only at age 12 or 13. However, it should be pointed out that there's a co-development of BPD, internalizing and externalizing. So once there is the onset of personality pathology, it's not that the internalizing and externalizing symptoms disappear. They remain comorbid throughout the lifespan, and this is certainly a pattern that most clinicians will identify. But the idea that BPD, that we don't need a construct of personality pathology or BPD in particular to capture what might be going on with a young person is not well substantiated by the literature. There seems to be something special about personality function that helps us predict outcomes, that helps us distinguish kids, more severe kids from less severe kids in a variety of outcomes. What about this idea that adolescent personalities are still developing and that they're therefore too unstable to warrant a PD diagnosis? And there are really two pieces of evidence that we need to think about here. The first is the well-known fact that there are from day one temperamental and individual differences among babies in terms of how they manage emotions. And so the dimensions typically measured for babies is approach and avoidance, which map onto internalizing and externalizing dimensions of our personality function. And so from day one, there are these sort of individual differences. And it turns out that these individual temperamental differences, personality differences, are quite stable throughout childhood, adolescence, and then adulthood. So this idea that we wake up at age 18 and suddenly have a fully formed personality is not true. Those individual differences between people are already present from day one. and are really maintained throughout the lifespan. And this is also further substantiated then by the fact that we can use these measures that can adequately diagnose a personality disorder as distinct from other problems that young people may have during adolescence. Finally, the myth or bias that is actually most heavily weighted by clinicians as the reason for why they don't assign a borderline or a PD diagnosis, this idea that PD is long-lasting, treatment-resistant, and unpopular to treat. By and large, this idea of personality disorder being so different from depression, anxiety, substance use in this regard has been debunked. The first person to do this was Mary Zanarini, who showed that people do get better over time. We have, of course, a range of treatment studies that show that people with personality pathology do respond to treatment. This is just data from our Menninger sample where we followed a large, over 500 kids up over 18 months. And you can see this decline in borderline symptoms as a function of treatment, but then a sustained decline over 18 months for parent and child report, suggesting again that this disorder is not as intractable or untreatable as we previously thought. I think the most compelling evidence in support of early diagnosis and this idea that we're not stigmatizing someone when we give them the diagnosis comes from people with lived experience. This is Ocelyn Baltazan's paper in a collection of paper in Current Opinion in Psychology that we published last year. I invite you all to go and look at it. It's free, it's online. Current Opinion Current Opinion in Psychology, and just look for developmental aspects of personality disorder, and you'll find a whole collection of papers on this topic. But here, Ocelyn, who is a person with lived experience, writes, striking a balance between care and stigma remains a key challenge in this area. Patients, unlike some clinicians, accept a personality disorder diagnosis positively as it contributes to identifying disease rather than negative aspects of themselves. Moreover, delaying treatment increases the likelihood of a vicious cycle of functional impairment, disability, and therapeutic nihilism. Thus, late intervention and the gap between research and clinical practice can have deleterious effects on individuals' social and societal levels. And so really a plea from not only people with lived experience, but also their families. I've spoken to so many parents who just wish that, like in Henry's case, along the way, someone assessed personality function, because in all of the cocktail of medications that Henry would have received, all of the missed opportunities, all of the misplaced treatments that these young people receive, where personality function is not a target of treatment, years of suffering could have been avoided. And so for me, this is the most compelling piece of evidence, is that our clinical community is being asked to please diagnose and treat the disorder when it emerges, so that we can get young people back onto a typical developmental track as soon as possible. So if we then revisit these myths or biases, we can say that psychiatric nomenclature does allow the diagnosis of PD in adolescence. While certain features of Bpd are normative, some young people do not grow out of symptoms, and the features are then symptomatic of personality disturbance. The symptoms of Bpd are not better explained by traditional Axis 1 disorders. The construct of personality function brings something to the table that is not well explained by depression, anxiety, substance, and so forth, and deserves our attention in our treatment plans. Personality is relatively stable across development, and there are valid and reliable tools to diagnose PD in adolescence. Personality challenges do improve in response to treatment, and those with lived experience ask us to help identify the underlying problem so that it can be treated. So in summary then, personality pathology is like a syndrome that onsets in adolescence in adult form. Differentiation from internalizing, externalizing psychopathology has been shown in terms of correlates, course, and incremental prediction. And internalizing and externalizing precedes the onset of BPD, but continues to coexist. And so this is just a sort of visual representation of this over the developmental onset. First, we have this sort of internalizing, externalizing picture that you saw in Henry as well. And then this really, if we don't look at personality function at this stage, this may then morph into an additional layer of complexity with a borderline personality disorder, or what I like to just call criterion A dysfunction. Criterion A then referring to maladaptive self and interpersonal function as defined by DSM-5, Section 3's alternative model of personality disorder. We know that BPD and criterion A function are very similar in terms of what they capture. But this is then on the severity spectrum, with internalizing and externalizing not being quite as severe as personality pathology, which is not as severe as, of course, thought disorder. And that is the psychopathology sort of severity spectrum over here. And so the question then becomes, why do we have this later onset of BPD in adolescence? Why don't we see the onset of BPD in an 8-year-old, even though there might be already some of these traits of emotional reactivity and impulsivity and so forth? What is it that happens in adolescence developmentally that didn't happen before that could account for this onset of personality pathology or personality challenges in adolescence? And what happens in adolescence is that we become a person, or put differently, we consolidate our identities. We develop a narrative of who we are as a person. Another way of putting it again is that we develop an integrated sense of self, an integrated representation of self. We draw on, we know this because basic personality researchers have shown us this. And the person that I have enjoyed discovering so much and has really helped me understand all of this is Dan McAdams, who put forward this model of personality development over time. And this is typical personality development in all of us. We all share this trajectory that when we are born, as we talked about earlier on, we are born with a particular trait profile. This is pretty much biologically based. It's got a high genetic load and it stays pretty stable, as I said earlier on, over time. But what happens around age 5 is that the person as agent, this is another layer of personality development that develops the person as agent. And so the idea to think about this is that we can have two people at the same level of trait. So let's imagine a person who is highly extroverted, a person that is very conscientious, and a person that is very good at managing people. That person could be either a serial killer or they could be an effective leader. And research has actually shown that that trait profile fits Ted Bundy quite well, but at the same time, it also fits effective leaders quite well. What's different between those two people is actually the goals and the values that drive them. So when we move through the world, we are not just victims of our traits, our dispositional traits, but there are actually decisions that we make, active decisions that we make along the way that are consistent with our goals and values. So this level of personality function is then on top of the trait level and permeates right through the lifespan. At age around 15, or a little bit before in some, the third layer of personality function emerges, which is the person as author. And this is where we then have for the first time the metacognitive capacity to actually reflect on ourselves, to think about ourselves from the outside in, and to begin to craft a story about who we are as a person. And this is where we become a person. This is where we begin to consolidate an identity. This is where we develop a representation of self, a story about ourselves that could be either adaptive or maladaptive. And so in the case of personality disorder, what we see is a maladaptive self-story or a maladaptive representation of self beginning to develop that is sort of superimposed on some of these maladaptive traits, goals and values, and then finally the life story. And so we have shown this actually in recent data for maladaptive personality development. This study was with using Barbara de Klerk's longitudinal data set, and Salome van Woerden took the lead on it. And we showed that maladaptive personality traits, that sort of first layer of personality function that Dan McAdams talks about, predicts this sort of later maladaptive self function 10 years later in young people via social problems and age 12. And if we are correct that these three layers of personality develop in this sort of sequential way, we have to also ask what drives the development of personality over these levels. And we have put forward this idea, Dan McAdams as well, that mentalizing capacity is critical in this development of the three layers. So, of course, very young infants have mentalizing capacity, but very rudimentary in the sense that they engage in social referencing, for instance, with their caregivers. We know that young children pass the theory of mind task at age 4, but it's not really until adolescence that we see this very abstract metacognitive reflective capacity develop for the first time. And so we want to be able to support the mentalizing capacity of young people across development, but especially as they move into this juncture where they have the capacity for increased perspective taking, and they have to manage multiple hypotheses about themselves through the eyes of others and begin to build an integrated sense of self. And so this is really what our target of treatment should be if we want to go beyond internalizing psychopathology, and we want to start thinking about how can we support or scaffold personality development in young people. How can we optimize personality development in young people? And we've put forward the idea that mentalizing capacity is going to be the key factor in helping them make sense, in helping them create meaning about who they are as a person, so that it's adaptive and helpful to them going forward. And so if we are correct that mentalizing is going to play a big role in personality development or maladaptive personality development, then we want to see association between mentalizing and BPD. And indeed, we see this link in our studies, various studies now. We have shown that mentalizing associates with BPD in adolescents. We've also shown that mentalizing, as measured through acceptance of thoughts and feelings in a community-based sample of adolescents, predicts an increase in BPD traits over a 1-year follow-up period. We've also seen that improvement in mentalizing is associated with reduction in BPD traits between admission and discharge in inpatient adolescents. If we are correct in saying that the key feature for personality pathology is identity development and narrative identity development, then we also have to show a relationship between narrative identity, BPD, and mentalizing capacity. This is Maisa Lind, who's been leading a range of studies with our data showing just these associations. So here we've shown that BPD traits are associated with identity diffusion and lower narrative coherence in adolescents. We've also shown that narrative coherence is associated with reflective capacity in adolescents, and that motivational aspects of narrative identity, so beyond the structural aspects of narrative identity, so these are then themes of agency in the community, are associated with better mentalizing and better emotion regulation. So narrative identity, themes of agency in particular, evidence also incremental validity in predicting borderline features over and above emotion dysregulation. And then we've also begun to validate measures of maladaptive identity in adolescents. If maladaptive self-function is so critical to personality function and dysfunction in adolescents, then we need measures that can capture maladaptive self-function in adolescents. And so one of the first that we've worked on is the ADA, which was originally developed by Kirsten Garth, Klaus Schmeck in Switzerland, and validated over there, and actually validated now in several languages, We did the first validation in an English sample, US sample, and this is currently under review. And then we have also validated another measure by Kirsten Goth, the levels of personality function. So this goes beyond identity diffusion, but also looks at the other aspects of criterion A function. And we've done this also in a US sample of youth, and my student Sophie Kerr has been leading that effort, and that paper is currently under review. Here we've shown in Sophie's paper that whether you are trying to predict group membership as psychiatric control or borderline control, the LOPF does very well. And this is important because, again, the LOPF can identify with great sensitivity and specificity who has a personality disorder versus who has just severe internalizing and externalizing psychopathology. And then in addition, this was just above clinical cutoff for BPD across the full sample of inpatients. In this study, what we've done is we've shown that the ADA shows invariance over age. And so, we do want to, with these measures, be able to make sure that our items are not biased to lead to over-response or under-response of a particular age range, given that we do see these normative increases in identity consolidation or normative decreases in identity diffusion over time. And in a large sample, this is Kirsten Goth's sample in Switzerland, we did show over 2,000 kids age invariance for the ADA, so that it's valid across all of these different age groups. But interestingly, we also see this sort of normative increase in identity diffusion across, just like in borderline traits that we see. Now, remember that this is not with in-person developmental trajectories, but between-person developmental trajectories. Even so, a 15-year-old shows a much higher level of identity diffusion than a 12-year-old on average. This is just a graph showing that this progression of identity diffusion tracks with borderline symptoms over time, just again bringing home that idea that criterion A or identity or self function actually captures more or less the same variability that we see, or the same kind of construct that we see in borderline measures. Now, what are the implications for treatment of everything that we've been talking about? Now, there's been a lot of different measures already different treatments developed and evaluated for adolescent BPD, DBT, MBT, TFP, CAT and HYPE, ERT, and then most recently GPM, Good Psychiatric Management for Adolescents. And several of these have had randomized controlled trials, DBT, MBT, CAT. And while there's a range of treatments now available, the field is very aware that there is a problem with access to these treatments. And so the next frontier is really to begin looking at how some of these treatments fit into a clinical staging model. And Andrew Channon has been taking the lead here, Joost Hapsebout. We've also started publishing on this. And so the idea would be that, all teens don't need the same level of dosage and time commitment in therapy using these evidence-based treatments, but that there are lighter versions at earlier stages of the disorder progression that can be provided. But this needs empirical verification. And so I think the field is really focused on that. I think we've also thankfully started moving away from this idea that if you're not trained in a particular evidence-based treatment, you cannot provide any services. I think that is part of the clinical staging model, and also part of this idea that a dimensional approach to psychopathology, where we can begin to treat pieces of a personality function without having been fully trained in one of these evidence-based treatments. The point is just not to shy away from providing some treatment to alleviate suffering, rather just because one hasn't gotten a DBT team together. So what I do want to emphasize today is that any of those treatment modalities will, if they do a good job, will address the building of the representation of self in a young person. Whether you do DBT or TFP or MBT, what you are going to do with a young person is you're going to scaffold this representation of self. So you are going to really increase mentalizing capacity. What do we mean with that? We know that to have a healthy personality, we have to understand a very basic point about how our minds work, and that is that what is in my mind is a representation of reality. I may not share it with other people's minds. My mom may not think the same thing. My dad may not think the same thing. My parents, or my boyfriend, my friends. So what I have in my mind is a representation of reality, and that representation may also change, and it is flexible. And so what we do with a mentalizing stance, which you can follow in any kind of treatment modality, is to really stop, rewind, and reflect on what is the representation of reality that is in my mind, not just about myself and my own mind, but also the minds of others. And we begin to negotiate that meaning so that we can make sense of it. And so the way we see personality function in young people is that it's really under construction. Traits are more or less stable and we are born with them, but the piece of our personality function that is under construction is really our criterion A function, the story that we are busy telling about ourselves, the narrative that we are busy building, and the representation of self that we are busy putting together. What is that representation going to be? And what does that representation say about how I relate to other people? And so these are the parts of personality function that we can tinker with and that we can help young people with through scaffolding that personality development, optimizing that personality development, because it is that part is still very plastic. It's not the stable part of personality. And so we really think about this scaffolding of personality development in young people. And when I work with parents and young persons themselves who are still under 25, I tell them you came at exactly the right time, because you are still, your personality function is quite plastic and you still have a lot of scaffolding around you. Remember, when young people begin to launch, a lot of that scaffolding begins to fall away because they move out of home, they're not in regular school anymore. And so we really want to get in there when a lot of the scaffolding is still possible, but we do need to work in teams to facilitate some of that scaffolding. Otherwise, we are not going to be able to increase the mentalizing capacity. The mentalizing capacity in turn is scaffolding the personality development. Without adequate reflective capacity, young people are going to really struggle to make sense of who they are, and they are going to build a representation of self that is very hard to undo, and that could be very maladaptive and unhealthy for them to help them to launch and to become independent. So I will finish with just a cheat sheet of how we've begun to think about mentalizing, really breaking down mentalizing into its core components, the very granular behaviorally based things that you do when you mentalize. And there's really 5 steps. The first is that we focus. So we are slowing down a person to say, hang on, this is going too fast. Can we just slow down so that I can get a clear picture of what we're talking about? Come sit here with me. Let's just think this through. It's going too fast, so bear with me. Let's just focus on this for a minute. It sounds like what you're saying is very, very important. Then we can move on to requesting meaning or providing meaning. So what it sounds like to me is that you are saying this, or what it sounds like to me, you are saying that. Did I get that correct? Let's look at this from the outside in. Let's pretend we're watching a movie. Is this what happened? And this is such a critical piece of mentalizing, because we're assuming that what the client is saying I can't possibly know what it feels like to be in her skin. So I have to request meaning, or I have to provide my understanding of what I'm hearing. Once we have a clearer picture of what is going on, we can then request expansion, or we can provide expanding. And this is where we really start using our imagination, and we say, well, you know, this sounds to me like that previous time when we talked about that, or, you know, I don't know about you, but what's in my mind when I hear what you're saying is this. So I see it differently. What do you think your mom was thinking when this was happening? So we're really expanding, and we're going beyond the immediate of the narrative, so that we can start expanding and really looking at different and alternative perspectives on what we are busy talking about. Of course, rewarding is critical. Thank you for slowing down with me there. That was a lot that I had to chew on in order to fully understand what's going on, and to get a clear picture of what you were trying to say. Regulating. So let's think about next time you are in this situation, what are the steps that you will take to sort of get to the point where you feel okay about things. So you're not going to use all of these steps all of the time, probably focusing request, provision of meaning, request, provision of expanding. You'll use most of the time. Rewarding and regulating will depend on the situation. But these are the components that we have distilled or identified that helps individuals make use of social learning. When one engages in these steps, it instills epistemic trust that the information that I am sharing with you today is in your best interest. Part of why the recipient feels this is because of the slowing down of the interaction when you take these steps. And most of you will be able to notice the emotion regulation effect that these steps have, mapping onto the theory of MBT, which is really that we develop self-regulation by increasing our mentalizing capacity, because it's really about slowing down and reflecting and making meaning to have a better understanding, which we can ultimately own in our subsequent behavior. So I will stop there, and I look forward to a Q&A with you all, and I thank you for your time. Thank you.
Thank you for participating. We are expecting Carla Sharp to join us in about 7 to 8 minutes. Until then, if you would like to make any comment, or if you would like to discuss anything, feel free. If you could kindly unmute when you're asking or when you're contributing, and tell us your first name, where you're coming from, that would be helpful. Thank you.
Hi, my name's Jenny. I'm from Perth, and I just wanted to say that was fantastic. It was really illuminating, especially around thinking about personality versus the other diagnoses, because, so often the clients that I see are, I think, burdened with a whole lot of labels that aren't particularly helpful to them. So, yeah, that was just amazing to have that sort of personality construct versus the other disorders explained far more articulately than I'm summarizing now.
Yeah, thank you, Jenny. Thank you for that comment. You're right. That was a brilliant presentation. Any other comments? Specifically, I'm interested in knowing your comments as to whether you believe personality disorders can be and should be diagnosed prior to 18 years of age. You might recall that in our national guidelines, that there is a NHMRC clinical practice guidelines for management of borderline personality disorder. It was published in 2012. in our guidelines, in our national guidelines, we make allowance for diagnosing people with a diagnosed borderline personality disorder from the age of 12, post-puberty. So post-puberty, after 12 years of age, the national guidelines recommends that you can consider making a diagnosis of borderline personality disorder if people seem to have those signs and symptoms. So any other questions or any other comments? I will pose all the questions which is in the chat box to Carla.
It's Carol here. I'm in Melbourne, Victoria.
Hi, Carol. How are you?
Hi, Sadia. I was really interested in the graph about the increase in BPD-ish symptoms in teen years, and then how it many people then it dies down again. And so I was wondering, do we have any clues about that 20% who go on versus the 80% who don't? How might we try and sort of distinguish earlier as possible the one? We don't want to be sort of providing Rolls-Royce treatment to everybody, but how we might be able to catch the 20% more effectively?
Yeah. In fact, that's a question I had too. We will try and ask Carla that question. Carol, if you would like to also type that question, that will be helpful. That's a great question. So we have another 5 minutes. If you want to make any comments.
I guess I'm wondering, Satya, whether you feel that you can start a conversation around some of those questions in the chat box.
Yeah, maybe on a general note, if I could say this. See, for a long time, we thought that we needed to have highly specialized treatments such as dialectical behavior therapy or mentalization-based treatments for anyone and everyone who had a diagnosis of borderline personality disorder. Now the field and the research is moving towards other forms of treatment, such as the common factors treatment. What I mean by common factors is that we now know that all the specialist treatments, such as DBT or MBT or transverse focus psychotherapy or schema-focused psychotherapies, they're all equally effective. Although there may be more evidence for DBT, there may be more research for DBT, all the treatments appear to be equally effective. And also there are more commonalities than differences between those treatments. So where the field is now moving is towards a common factors approach. And those common factors approach looks like is relatively easier to train and learn and as well as implement. So if we have to look at treatment for every single person with a diagnosis of borderline personality disorder in Australia, and if you have to look at DBT or MBT kind of treatments, we need about $3 billion per year. So the questions are, I mean, as Carla clearly asked, so do we really require those sort of expensive, highly specialized treatments for everyone? Or should we be looking at staging? Should we be looking at different types of treatment and different gradations of treatment and different intensity of treatment and different dosing of treatment for the different populations? So, and especially in the youth population, there's very good research coming out of Andrew Channon's lab. Andrew Channon is a specialist in borderline personality disorder from Melbourne, and he has contributed a lot to the understanding of BPD in under 18, and he has been working on clinical staging in order to precisely address this question. So those are some of my comments. If you'd like to, make any have any further reflections, feel free. Gillian, Gillian Broadbear, can I request you to pose the question that you asked to the broader group, and see if anyone wants to make any comments.
Sure. Thank you, Seth. Yeah, I'm Gillian Broadbear, and I lead the research at Spectrum. And one of the major foundational kind of constructs for BPD seems to be elements of sort of maladaptive attachment very early in life. And Carla, as far as I heard, she didn't touch on that. And I'm wondering whether very early intervention that improves the process of early infant attachment with a parent, particularly perhaps when a mother's already at risk, she may have BPD herself or other serious mental health problems, whether that might change the trajectory of that personality integration as someone goes through those vulnerable childhood and teenage years.
Yep. I don't know whether you're aware, in Victoria, we had a Royal Commission into Mental Health recently. And some of the recommendations are that we commence intervening as early as possible. We're looking at risk mothers. We're looking at 0 to 10 population. So the question which Gillian raises is very pertinent to the Victorian situation, and probably more broadly to the Australian situation. I have not seen enough research in this area, Gillian, myself. But there people have worked on this, but I don't know whether there is adequate evidence. But it'll be good to ask Carla if she has any information about it. Is anyone else want to respond to that question?
Yeah, hi, my name's Carmel. I'm a GP in Melbourne. I work with young people in a clinic in a community health centre. I guess my position on that is that the early intervention is absolutely the way to go. And I think looking at that attachment stuff is just super duper important. And anything that supports young families and parents raising their children is going to improve the mental health of our nation, I would think.
Yep.
Yeah. So I'm all for that.
Thank you. We may have some opportunity to do some research in Victoria around this issue in the months and years to come.
Well, that's very exciting. I'd love to know about that.
I'd just like to make a comment that Swinburne University runs a program for mums with a child from birth to age 15, I think it is. So mindful parenting. So if anyone's interested in that information, I'm happy to send you the flyer. They're currently seeking expressions of interest and I think it's going to be online. So distance isn't quite the same problem as it used to be.
Thanks, Rita. I think Jenny has raised her hand. Jenny, do you want to have a go?
Yeah, I was just wondering, is there much research being done into, treating the family system? Because I've come through it through Family Connections, and then I'm working on DBT groups at the moment. And, a lot of what we're doing is often, I think, treating undiagnosed BPD traits in parents. So is there much research being done into, looking at the family system as a whole in treating BPD?
That's again an interesting perspective, not to my knowledge, not the entire family system. There's one comment here from Chelsea. Yes, I would completely agree with you, Chelsea, that peer workers and psychosocial recovery coaches need to be treated. In fact, we need to train. we need to train the entire workforce. We have a generation of clinicians and mental health workforce that is not adequately trained in the treatments of bodily and personal disorder. So when I'm talking about training, I'm talking about training the entire workforce. There are a few comments here. As a family therapist, we look at treating BPD traits in the parents and symptoms showing in children. If anyone else want to make any comments about it, feel free. See, early.
Sorry.
Go on, Kamal.
Yeah, hi. I would think that there would not be an occasion where a young person potentially being diagnosed with borderline personality or other personality issues would occur in isolation. And so I guess engaging the family is going to be also really pivotal.
Of course, yeah. So in fact, that's one of the treatment principles, that if you're working with people with the borderline personality disorder, you would want to work with families and carers and educate them, support them, and involve them in the treatment planning and the crisis planning. Do you want to make any comments about that, Rita?
Sorry, I'm focused on finding that flyer. I missed the question.
No, the question is the role of helping, supporting families in the treatment of people with borderline personality disorder.
Well, my personal opinion is that it's essential. To me, it just doesn't make sense to treat the person in isolation or to offer them support, and they go home to the environment that may be triggering some of the behaviours or the distress. So in my role at Spectrum, I run a day care workshops for carers, very much based on my peer experience of supporting a daughter with BPD. And we certainly have fantastic feedback from that. It's quite a generic workshop, very much focused on the needs of the participants in the room. And we see some people come in looking extremely stressed, not really willing to engage in the morning. And by the end of the day, they're laughing and making jokes. So it's just really fascinating to see how providing a validated, supportive environment is helpful. I do feel that it's most positively done in a group of other carers rather than one-on-one with a clinician. However, in the absence of being able to set up a group, certainly I would encourage everyone to give the families some supportive information to help them understand what's happening in their lives.
Thank you, Rita. I'm going to respond to a couple of comments. Some of the questions you've asked, I'm reserving it for Carla Sharp, so that I don't want to take away her thunder. A couple of questions here I might comment. One is, again, Jenny's comment regarding Chelsea's comment about the fact that there are thousands of university-educated counselors who are ready to go, but are only able to help through low-paid work in the not-for-profit sector, or only working with financially capable private clients. So government support is needed. Again, fully agreed. I'm sure Rita would agree that the foundation would support that. We need to, as I was saying earlier on, when we're looking at training, we need to really have a national training strategy and train the entire workforce. So if we are really serious about treating every single person with borderline personality disorder, we can't just depend upon only psychiatrists or psychologists or nurses. We need to look at the entire workforce, including peer workers. The Other comment is about the use of psychedelics. Now, in personality disorder, yes, there is the research, the evidence for using psychedelics in the treatment of borderline personality disorder needs to be developed. It's a very interesting area. We are quite interested, and I might ask Gillian to say a few words if she wants to about this. Now, we want to be also be cautious. We know that still we haven't got the TGA approval in Australia, and there are lots of people lobbying to get the approval. Once the approval is done, and once we can attract some funding at Spectrum, we are keen to do a research using psychotherapy and psychedelics. In principle, it makes sense because psychedelics are going to break down those entrenched patterns of thinking, feeling, and behaving, which is the definition of a personality disorder anyway. And if we can break down those entrenched patterns, then it gives the person opportunity to reintegrate their personality structures. Gillian, do you wish to make any comments about this? Gillian Broadbear is an associate professor and senior researcher at Spectrum. Gillian.
Yep, thanks, Satya. Look, I don't have my head across the whole literature on this, but there is a lot of work going on, including our own federal government has put money up for people to apply for to investigate this application of psychedelics in Australia. I think that field will probably go in this direction as an option. My sense is that it could speed up the psychotherapeutic process by maybe removing some barriers in the way that people think. I think it's got to be managed really carefully. The comment about EMDR and the client coming out of that very vulnerable, I think there would need to be some quite specific management strategies and care taken in the introduction of psychedelics into someone's treatment plan. So I think we shouldn't rush at this. We could do some damage and spoil the future of this as a treatment possibility.
Thank you, Gillian. There are a couple of comments about trauma and autism spectrum disorders. So the current research shows that trauma is extremely common in borderline personality disorder, and it is a very significant risk factor for development of borderline personality disorder. However, trauma is not an essential criteria for making a diagnosis, as well as trauma is not essential for development of borderline personality disorder, if that makes sense. Having said that, if someone has experienced trauma, it is vital that we work with trauma in that person, if that person is willing and wanting. The general principle is that we wouldn't want to rush with trauma therapies at the very beginning, unless it is stopping a person from engaging in treatment. Now, there are DBT, PTSD protocols available, and similarly, even mentalization-based treatments, trauma has been considered. The link between the next comment is about autism and borderline personality disorder. We are quite intrigued about this association at Spectrum. We do see a lot of patients where there's an overlap with autism spectrum disorders. So we are keen to do some more research in this area. At this stage, our understanding is this. If someone, there can be two cohorts of patients. The first cohort is people having a primary diagnosis of autism, and those people exhibiting BPD-like symptoms as a secondary diagnosis. So in that case, the primary treatment is going to be autism, whatever treatments available, and the usual BPD treatments generally, the evidence-based treatments such as dialectical behavior therapy can be helpful for treatment of the secondary BPD symptoms. The other possibility is that when people have experienced severe attachment disorders and severe deprivation of parenting and neglect during childhood, some people with diagnosis of borderline personality disorder exhibit secondary autism-like symptoms and features. In that case, the prognosis is probably a little more better if we can adequately treat borderline personality disorder. Then we have noticed that some of the secondary autism features also tends to remit. I wonder if people have any comments about that, what I've said. Okay.
Well, I guess, Sathya, my very uneducated and layperson thought about that is that if a person has the features of autism as a very young child, their environment quite possibly isn't making any sense for them. And there may be, and it may not, the parents or the major caregivers or school or whoever it may be may not actually fully understand the needs of the child. So there's a little bit of a misattunement between the two. And for the child, it may actually be experienced as trauma. So it's just based on my observation working with a lot of carers, where one family member, usually the daughter, has a diagnosis of BPD, and a sibling, usually a son, not always, has got a diagnosis of autism, and particularly Asperger's.
Yep. Thank you, Rita. I would like to draw attention to a couple of things that Rita just mentioned. One of it is we are seeing this pattern where a female child in the family has borderline personality disorder, and the male child having autism spectrum disorder. And it may be just an association, but that is something which we are noticing at Spectrum. We have no evidence for this, and there's no research. This is just an interesting observation. Also, Rita made a point about misattunement. That again is something which I would like to draw our attention to. One of the ways to understand the development of psychopathology and borderline personality disorder, as Lois Choikin, one of the experts in BPD from US, has pointed out, take an example of a child who is predisposed and is at risk to develop borderline personality disorder. And we know that one of the brain pathologies in borderline personality disorder is that there is an hypersensitive and hyperactive emotional system, that is amygdala. Now, let's take an example of a child, let's say about 10, 15 years old, who has a sensitive emotional system, which is hyperactive amygdala. And the child is watching a movie along with parents and sibs. And let's say this movie is a very sad movie, and it can bring some tears into people's eyes. However, the child who has a very, very sensitive emotional system may start crying for a long period of time. Let's say for half an hour, and the child is not able to control crying. You can imagine how the rest of the family is going to respond. So the rest of the family may respond saying, don't worry, it's just a movie. And they're trying to console, they're trying to reassure the child. But the child's experience is very different. So, and the child can actually experience the reactions of the sibs and parents as invalidating. So as you can see, even if the families are doing good enough jobs, it can be perceived as invalidation by the child. So that's the point about misattunement that Rita was talking about. Rita, would you like to make any comments about the slides? I think there are a couple of people are asking about questions about whether they can have access to slides.
So yeah, I've responded to that. Yes, Carla has sent me her slides, and I'll send those out with the link to the uploaded file. There was also a comment about training, and that's something that the foundation is very passionate about, and one of the reasons for hosting events like today. And the foundation is rolling out a national training strategy in collaboration with Spectrum. And I think the training is happened in 4 states, and it's currently happening in WA, based on the common factors approach to treatment. And as part of the strategy, there is a train the trainer component. So hopefully training will become more readily available. And also we are seeking funding in order to roll out this training with PHNs and with anyone else that is able, willing and able to run it. So I'll put the best email for me in the chat box. If you feel that your organisation would like to run the training, please contact me.
If you are in Victoria, Spectrum has developed a core competencies training framework, which is based on all the common factors of highly specialized and non-specialized evidence-based treatments for borderline personality disorder. And this training is available for every single mental health clinician in Victoria eventually. We have manualized the training, and so that training will be available for everyone in Victoria. Our hope is that eventually this sort of trainings are available for any clinician or any worker who is interested in contributing to the welfare of people with borderline personality disorder.
I'd also like to mention, for anyone that might be interested, there's an online e-learning module which has been developed by Project Air as part of the strategy, which is available to use at your convenience.
Yep. Rita, do we have any news about when Carla might be joining us?
No. I haven't heard, but had a response to my email.
Okay.
So, yeah.
I'm just trying to see if there's anything else. Yep, there's a comment here saying that, could you speak to the topic of young people getting a late diagnosis of autism? I believe that emerging BPD should be considered as part of the assessment, but many clinicians seem to over-focus on autism. Have you encountered this problem? It's a question from Sue. So that's what you said just mirrors my experience. In the last 3 years, I've seen a lot of patients with borderline personality disorder actually getting now a new diagnosis of autism, either in place of BPD or instead of BPD. So which is a bit intriguing. One of the possibility is that the NDIS support for people with autism, with people with autism, and you have a diagnosis of autism, may be a factor which is attracting people for a diagnosis of autism. But science-wise, what we think is that you could have autism-like symptoms in a person with borderline personality disorder, clearly. It's not autism, it is autism-like symptoms, which is a secondary, if one wishes to give a secondary diagnosis of autism, saying that, borderline personality disorder with secondary autistic symptoms, that's fine. But it is not likely to alter the treatment of BPD for that person. However, if someone has a primary diagnosis of autism with secondary BPD features, then the story is different. Okay. I'm trying to read through some of the questions. Do people want to make any other comments? If you wish to answer any of the questions raised by others, feel free. Rita, do you have any answers for this question? Do we know when we get the offer for Udonga? I assume it's about training.
Need to look up on the website.
So we are going to do some training in Canberra, the core competencies training. I don't know whether people can access it at Canberra.
Albury Wodonga is on the 24th and 25th of June. Are you, sorry, what Wodonga? I'm unsure where Wodonga is.
Udanga, Aubrey Udanga, I assume. Oh no, Wodonga.
So, yeah.
Aubrey.
Yeah, so 24th and 25th of June. If you send me an email, I'll send you the link to register an expression of interest.
There's a question about whether there's any training in Melbourne. Look, if you would like to keep an eye on Spectrum website, we do bring up this training again and again. We have just done a couple of them, but we can do it again.
And the foundation will also endeavour to hold more of these forums as well. It's great to have such a representative sample from the mental health workforce.
Our apologies for not being able to have Professor Carla show up with us today. We'll find out what happened. I think something must have gone wrong in accessing this link. So thank you very much for attending today. And before I finish, I'll hand over to Rita. So if you want to say a few words and close the session, Rita. Thank you.
Okay, thanks, Sathya. I'm just going to share a slide. Just put it in the chat box for those that had to leave. I'd like to thank everyone for attending and for all the questions. So to help us guide future sessions like this, very much appreciate your assistance in completing a short survey. So there's a QR code there, or access via SurveyMonkey. And yeah, thanks, Marcela, for joining from Mexico. I hope it was worthwhile for you. Getting late in the evening there, I think. I know it's 9 p.m. in Houston. So maybe Carla's got caught up with something. So thanks very much, and I hope you enjoy the rest of your day, and I'll send this link out as soon as I can.
Thank you.
Thank you.